So I'm going to just brush upon what all we already discussed just now, not a major long topic, very short topic. So we'll try to finish as fast as time. So whenever spondylolisthesis comes in mind, there are few classification that comes in our mind, starting from Meyerding's, which was degree of sleep, how much your vertebra has slipped over one over another. And, they divided into grade 1 to 4 and grade 5 is complete spondyloptosis. Then came the Wilson, Newman and McNabb classification. They focused mainly on etiology of the spondylolisthesis, right from dysplastic to iatrogenic, and everything was included on etiological basis. Marshati, they modified it and they basically divided etiology into two broad groups. One is, which is a developmental spondylolisthesis, which includes the dysplastic one, and second is acquired, which is traumatic, degenerative pathology, which you acquire during your age. So, these are more etiological and grading classification. Then McTheong introduced the concept that you need to focus on pelvic parameters, lumbopelvic dissociations, lumbopelvic asymmetry would clinically impact the results of your patient, whether it is a pediatric patient or an adult spondylolisthesis, and which was further modified by spine deformity study group and came the SDSG classification. I'll take that into a little detail later on. So we have two X-rays here, can we say that any difference between these two X-rays? These two both are grade 2 spondylolisthesis. Is it yes? Is it no? Or not sure. So if you compare these two X-ray, what we were talking, there is no doming of sacrum, more or less no trapezoidal vertebra here, both are lytic listhesis. And if you look at here, there is a doming of sacrum, a trapezoid shaped vertebra. So you can say that one is a dysplastic one and second one is a degenerative one along with the spondylolysis. So the treatment changes, how your dysplasia is present in your patient. So what is this dysplasia? How do you suspect dysplasia? What are the features of dysplasia? So it starts with patients who have spina bifida or spinal cord anomalies. Patient would have a small transverse process, dysplastic facets, trapezoidal L5 and rounding of sacral dome. So these are the cardinal features which may or not all, but some of them which you will see in your patient. When we talk about high dysplastic patients are significant lumbosacral kyphosis. There will be lumbar hyperlordosis, pelvic retroversion or a vertical sacrum, trapezoidal L5 and sacral dome anomalies. And these are the spondylolisthesis which always progress and requires treatment and a solid fusion. So this is a patient where you can see there is a vertical sacrum, there is doming of sacral end plate and a trapezoidal vertebra. So this is a classic example of high grade spondylolisthesis. So what are low dysplastic ones? So low dysplastic one are normal L5S1 end plates, no hyperlordosis, only translation, maybe having a multi-level lysis, and slip progression depends on disc degeneration. So not the mechanical shear force or a constitutional arrangement of the lumbosacral junction, but the degeneration plays role whether it will progress or not. And sometimes self-stabilization can also occur, and these are the patient you can plan to treat conservatively. So we jump on to the radiological measures. There are few things which we know, right from the slip angle, PI, PT, SS, and the lumbar lordosis. So assessment of slip angle, I'll not go into detail how to measure because I have been given very short time. So lumbosacral slip angle is a measure of lumbosacral kyphosis. How much kyphotic deformity is present between a transition zone between lumbospine and the sacral spine. Pelvic tilt, we all know how to measure, which is angle of rotation of pelvis on the femoral head. Positional parameter, compensatory mechanism of the body whenever spine is under imbalance, and which is limited by hip extension. So beyond a point, pelvic tilt or pelvic retroversion doesn't happen, and other compensatory mechanism needs to come into play. PI, which is a fixed parameter, and you can divide patients based on this PI into low PI, high PI patients. The interrelation is PI is equal to pelvic tilt and the sacral slope. And as I mentioned, the pelvic incidence is morphological parameters unaffected by the spine. Rosoli came that if you have a pelvic incidence which is in a varying degree, your entire spine shape or a global shape changes. So low PI patient will have a low lumbar lordosis, and high PI patients would have a higher lumbar lordosis. And goes without saying that these are the patients which will experience more shear forces and can have further problem with your spondylolisthesis. So if we need to understand the basics of biomechanics of spondylolisthesis in high grade 1, the listhesis is a spinopelvic dissociation. You have to bear this sentence in mind. Listhesis is a spinopelvic dissociation. It's not only the slip. Alpha S1 cannot be viewed in isolation. The sacropelvic complex moves as a unit, and sacrum is a part of spine as a pelvic vertebra. So as I just mentioned that, whenever you are talking about high grade spondylolisthesis, these are 4 morphological components: the sagittal plane translation, lumbosacral kyphosis, translational stenosis or a nerve compression, and spinopelvic imbalance. And whenever you plan a surgical treatment, all these 4 parameters needs to be taken into account before you decide a particular treatment. So what are these high grade and low grade? The low grade is less than 50% of slip, and high grade is more than 50% of slip. Further, you can divide into high dysplastic and low dysplastic, and spinopelvic balanced or imbalanced based on your sacral slope and pelvic tilt. So now we come back to SDDG classification, and they divided into first grade, low grade, high grade. Then based on dysplasia, they divide into low dysplastic and high dysplastic. If it is a low PI and high dysplastic, they divide it into type 1, type 2. If it is low and high PI and high dysplastic, they divide into 3 and 4, and same in the high grade slip. So this 3 things comes into most important point when you decide a treatment, whether it is a low grade, whether dysplasia is present or not, and the spinopelvic balance. So these 3 parameters would decide the treatment plan. So in summary, whenever you plan a treatment for high grade spondylolisthesis, identify first the grade of listhesis, decide whether low grade or high grade, decide the dysplasia, whether low grade dysplasia or high grade dysplasia, assess lumbopelvic harmony, whether it is a balanced or unbalanced spine. Try to restore the balance, try to decompress the nerve, and always try to achieve a good solid fusion, whichever technique you are employing for your surgical treatment. Thank you so much.